Thank you. I have just a disclosure here in that I am a speaker for AbbVie Pharmaceuticals, who produces one of the gonadotropin-releasing hormone agonists that's used to treat, under FDA guidelines, precocious puberty in young children. And that same hormone is what is referred to as puberty blocker hormone in the proposed treatments of transgender individuals. I will talk about it in its context of the recommendations for treatment, but it will state up front it's off-label, and the company will not specifically address that, at least in public. And by the end, you'll get a sense of how I feel in that regard. Terminology. The term transgender indicates that a person feels they are trapped in the body of the wrong sex. It was originally called transsexual instead of transgender, and that was a term that was brought to in the 1950s through the 1970s by the folks in Hopkins and at the Kinsey Institute. Gender identity as a concept was something that Professor John Money at Johns Hopkins Hospital, coined the term as the identity of the intersexed self. Money believed that gender was recognized by the patient as early as 18 months of age. Now, that was an opinion. It wasn't based on anything other than his personal observations. There was no science behind that, but most of what he has written in his publications is not based on science, but is just based on his specific opinion. Gender, prior to Money's bringing it on as a term to describe the internal sex self, was a term that was reserved for languages, descriptions of nouns as either being masculine or feminine. Had nothing to do with biologic sex at all of the human being. So if you look back in literature, the term gender was not applied to humanity until John Money began that process in the 1950s. Today, if you have a 50-50 chance if you put an application in for a Delta frequent flyer card, you're going to be asked your gender. In the state of Georgia, where I live, they'll ask you your sex for the driver's license, but gender and sex are basically used many times interchangeably to define whether or not you are male or female, and now in this day and age, of course, many things in between male and female. Disorders of sexual differentiation are completely different than transgender. These used to be called intersex conditions. It is either an undervirilized XY male, biologic male, or an overvirilized XX female who has some degree of ambiguity of the external genitalia noted at birth. You can occasionally have both XX and XY germ cell lines in the same human being, and that was what was referred to in the old days as a true hermaphrodite, but it's now not referred to that because it's not very politically correct to do so. These patients do not have issues with their gender identity, so that the transgender activists try to bring these people into their fold as if they are prevalent, as maybe as much as 1 in 300 individuals are somehow intersex based on criteria that they develop, when in truth the incidence of intersex in terms of mixing these problems is probably about 1 in 20,000. So I refer to these guys as the triple threat. I used to refer to them as the Three Musketeers, but I was told in a critique of my prior talks that made them kind of heroes of sorts, and so we don't want to really think of them that way. John Money, who I mentioned before, he was a Harvard graduate from their psychology program, and he came to Johns Hopkins in the early 1950s. And he created what was called the psychohormonal group, and I'll come back to some of his concepts in just a minute. He assessed infants with disorders of sexual differentiation and children with early pubertal development. Hopkins was sort of the epicenter back in the 60s and 70s of a place to send your child who had disorders of sexual differentiation to assess how it happened, what it was clinically. And they developed and delineated all the steroid biochemistry pathways from cholesterol all the way through through cortisol to show where these things went awry in utero in terms of the development of the fetus along the way. He treated adult transsexual patients as well, even though he was allied with the pediatric endocrine division through the psychohormonal group. The adult endocrine folks at Hopkins wanted nothing to do with him or his treatment, but he had a cadre of adult patients, a small number over the years, less than 20, who he treated recommended treatments for taking their sexual appearance from one sex to the other. The second in the triple threat was Henry Benjamin. He was a family practice physician, no background in mental health, no background in endocrinology, and he practiced in New York City and then went to San Francisco in the summers because he liked the weather there. And between those two cities, he decided he would treat patients who had issues with transsexuality. He facilitated the sex change of the famous Christine Jorgensen, who was one of the more notorious transsexuals of the 1950s. And the last one is Alfred Kinsey, who was an entomologist. Now you might ask how in the world an entomologist gets into the world of sex. He actually studied mud wasps, and he was famous for that. He was on the faculty of Indiana University over in Bloomington here in the state. And he was asked to teach a class on marriage and sex. And he took that class by default. He had no training, but he kind of got intrigued by it because he kind of liked sex. And so he took that on and developed the Kinsey Institute as a result. So Money's legacy at Hopkins kind of fell to pieces because he published several books. And the one copy of his book, Man, Woman, Boy, Girl, he was talking about the great success of his case of one of male twins who had his penis accidentally burnt off with a botched circumcision. The guy found a little bleeding point and took a Bowie knife to just touch it up a little bit and burnt the whole penis off. And that child was then subsequently reared as a female. And John Money furthered that whole process, counseled the family, counseled the patient. That girl and his twin brother were raised together. John Money actually encouraged the two of them to experiment sexually with each other as young children. That boy eventually learned that he actually was a boy, and in young teenagehood requested that he be fixed as much as could be possible with whatever amputated phallic stump was there to be externalized so that he could stand up to urinate and possibly have some form of intercourse. That was accomplished, and he got married, and then he committed suicide. That's when things really began to fall apart. The majority of the infants with disorders of sexual differentiation that John Money reverted changed the concept of how they appeared to being at odds with their biologic sex. Most of them reverted back to their biologic sex over time in later years. So the standards for more appropriate management of disorders of sexual differentiation were subsequently created, and there's actually a division within the Pediatric Endocrine Society that it has international pinnings that has developed terminology and plans. And in the state of California, as I understand, there's a bill that was trying to be passed that hopefully will fail, where no surgery can be done to change any appearance of genital structures until the child is at age of consent, because of course they can't, they're not old enough to understand what's going on until they're the age of consent. Now, that seems kind of odd that the same state that's doing that is pushing for 11 and 12-year-old girls to be able to decide they want to have mastectomies when they want them. So a little bit of a disparity and hypocrisy there. So none of in the Money's group, especially the adults, none of the undercurrent psychological morbidities resolved. And they studied the entire population of his adult transsexuals. He did not take kids who, as in today's world, feel that they're transgender and push them through a process. He only worked with adults. And their morbidities, mental morbidities, which existed pre-treatment with his protocol, still persisted. And so when Paul McHugh arrived to take over the chairmanship of the Department of Psychiatry at Johns Hopkins in the early 1980s, he reviewed that. He actually demanded that review be done. It was done. and published by Dr. Meyer, and it basically showed that his program was a dud. It was embarrassing, and so John Money's program was closed. McHugh was very well known at the time he came to Hopkins as being a preeminent, internationally renowned, highly published psychiatrist in the field of sexual behaviors in humans. The Harry Benjamin Society, which is probably the only thing that's really left of Harry Benjamin's legacy, was organized to honor the memory of Harry Benjamin after he passed away. It was an international group based primarily in Europe because nobody in the United States wanted to have anything to do with it. It gathered transgender persons and those who promoted medical and surgical treatment. That's it. That's what it was. It wasn't a professional group that did certification, licensure, and training. It was if you're interested in transgender or you are transgender, we have a place where you can come. And this is pre-internet days. So these folks would, talk to each other by letters and telephone calls and developed a network of support for themselves. They changed the name of the Harry Benjamin Society to the World Professional Association of Transgender Health, or what we refer to as WPATH. Although the membership requires absolutely no professional degrees, no certification, no training, it just requires that you pay dues. Now, the Kinsey Institute, the last vestige of Alfred Kinsey, evaluated human sexual behaviors. As I said, Kinsey was asked to teach the course on marriage and sex to Indiana University college students. He was the second choice to people that they wanted to run that program, and by a fluke, he ended up taking over the job by default. He established a survey of 350 questions, which he had memorized in his head, and only he gave the survey. He did not allow anybody else to administer the survey. And it was done with individuals, men and women. Many of the subjects were incarcerated individuals. That wasn't necessarily explained when he wrote his books. Many of the women were prostitutes. And so you might imagine in incarcerated men that the sex life in prison might be skewed a particular direction. And in prostitutes, you might think that there might be some kinds of behaviors that would not be accepted as the norm in the population. Again, that was not brought up, and he referred to the prostitutes as college women, and the way he couched all the details is very interesting. This is all really beautifully described in the book by Judith Reisman on the subject of the Kinsey Institute. He created the impression that many previously deviant behaviors were actually part of the normal human sexual behavior, and his books were revered internationally. He studied the sexual arousal of infants and young children. The infamous Table 34 that it's referred to. Now, when I saw that first referred to in Reisman's book, I was wondering, like, if you sat in a restaurant and they put you at Table 34, do they have a table where these children were evaluated? But Table 34 is actually a table of data in his book, so just to put it in perspective. But he actually studied things like how often infants and toddlers could be aroused to some sort of orgasmic event back to back to back, and he published all that. And the data is all available to be seen. That, of course, would not be a study that would be recognized as moral or ethical in today's environment. So, the U.S. landscape for transgender treatment from about 1980 to 2006, where were we? I finished my fellowship at Johns Hopkins. I had the exposure to this crazy man, Dr. John Money, who, in my own personal opinion, having dealt with him on a weekly basis throughout my fellowship years, I would describe him as a classic pedophile pervert. There was no question in my mind. Name calling is not a very good thing to do, but knowing his beliefs and what he taught us, there was no question that I thought he focused on sexual perversion constantly in his presentations to us. And he offended any number of people, particularly the more religious female fellows he would target specifically to upset them greatly with his lectures. So he was there at Hopkins, and his program kind of died at the end of the 1970s, early 1980s. And I left that fellowship. It's very interesting because of my situation in the Navy where I was given an opportunity to be a free fellow at pretty much any endocrine fellowship across the country. I got to go and interview at a wonderful number of very reputable places across the country, and settled on Johns Hopkins because of the faculty and the reputation there. But once I got accepted there, I kind of got the other people who had accepted me kind of angry because I didn't go to their programs. And one of the rebuttals when I would see them at meetings was, "Oh, you're at Hopkins where John Money is. Good luck, buddy," because he had a reputation of tainting that venerable institution with his nonsense. So Hopkins was the laughingstock of the academic endocrine programs for having fallen for Money's sort of charade and folly. No reputable medical or surgical programs treated any transgender patients in this country. You could not go to any university center, any academic center, any major medical center, and find any kind of treatment or intervention for adults who were transgender. Harry Benjamin Society, or WPATH, had an underground network of willing providers in the United States in such places as Billings, Montana, and other small cities. You could network and find a surgeon that would do your genital revisions or your mastectomies. You would find doctors in small clinics who would provide hormone therapy with estrogen or testosterone. But it was literally underground. There was no way that was accepted by the mainstream medical community all the way through 2006. I had a patient that came to my private medical practice after I moved to Georgia when I'd retired from the Navy. It was a 13-year-old boy whose family had moved. I think this was the fifth move in this 13-year-old boy's life, as Dad was in the Army and would be temporarily stationed in various places. They had just moved from California, and the boy was severely depressed and went to a psychiatrist in Los Angeles who said, I know what the problem is you're transgender. With the next move, let's go ahead and have you assume the role of a female. And he talked the parents into doing that, so they arrived in Georgia with their new daughter. They had several other children in tow, and this child came into my office because he wanted estrogen therapy. And we really did not have GnRH agonist therapy to offer at that point in time. He was in Tanner stage 3 of puberty and walked in the door with long hair and a dress and a female name, and it was requested that I keep this secret from everybody in the office, that only I was to know in the privacy of the exam room that this was actually an anatomic male. I plotted his height on a male growth chart, just to kind of be a little bit defiant, and put that in the chart. But I did go ahead and treat him with estrogen after our practice attorneys suggested that I protect ourselves by having an informed consent that was designed specifically to protect us from any liability from secondary side effects, and I explained everything we knew about estrogen dosing in males, which was very limited. At that time, I could not find anybody in the country, in the pediatric endocrine world, who could advise me on what I should do. And when I finally pulled a couple of punches and said, I need some help, my old program director, Claude Mijon, who was still alive at that time, said, give him estrogen. That's all I can say. We don't have any experience with this to know what to do. So that patient, within about 6 months, moved out of the area, again, another transfer, and I was lost to follow-up. I did refer that patient up to my Army endocrine colleague in Bethesda, Maryland, at the hospital there, but I don't know the patient ever showed up in the clinic. So that's the entirety of experience in this country and colleagues. There was nothing going on. Keep that in mind compared to what we'll see in today's environment. So the European landscape was a bit more lenient. From 1950 to the present, medical and surgical treatment converting adults in Denmark, Sweden, Belgium, and the Netherlands, doing both medical treatments and surgical treatments. Medical and surgical treatment of children in the Netherlands from about 2000 onward. And in the Canadian landscape from 1980 to the present, Kenneth Zucker, a clinical psychologist in Toronto, who ran a gender identity disorder clinic in the Center for Addiction Medicine in Toronto. He evaluated nearly 600 kids, age 4 all the way up through late adolescence, and evaluated them. He developed the standard of care, if you will, for in-depth psychological evaluation and treatment of both the patient and the family. 90% of the biologic males and 80% of the biologic females that came to him with gender incongruence reverted to identifying with their biologic sex by the time they reached late adolescence. They were allowed to go through uninterrupted puberty. That is called the watch and wait approach, and that's what he refers to it as. Zucker was widely published in peer-reviewed literature, was considered the world's preeminent expert on transgender medicine. He actually coined the term gender identity disorder and put it into the DSM criteria, versions 3 and 4, that's produced by the American Psychiatric Association. So there are two distinct pathways of treatment for transgender individuals now in the world, if you will. There's the watch and wait method that Kenneth Zucker had such an incredible progress with in getting the vast majority of those patients. I mean, if you think of a cure rate of 90% in cancers or other diseases, that's pretty impressive, even 80%. And then there's the gender affirmation treatment, which is the newest and the most prominent way to go in today's political environment. The watch and wait is based on aligning somebody with their biologic sex, and the gender affirmation is based on the theory that gender identity is innate, as if it's a biologic concept. The watch and wait method. It's referred to as conversion therapy. Very oddly, something that happens frequently from people who are opposed to you is they take the language and turn it around, and instead of leaving somebody in their biologic sex and having them confirm that, this is referred to as conversion therapy, because that's a nice sort of electric word in the world that applies to the same-sex attracted population, where they are converted back to straight people, supposedly, with all sorts of horrible tortures and ineffective treatments. So they just put the conversion therapy term onto watch and wait, when in truth it's an affirmation. It is anything but positive, anything but passive, rather. It's very active. The watch and wait, sort of that term that Zucker decided to apply, is not waiting at all and just standing by on the sidelines. It's aggressive intervention, evaluation of the psychological circumstances that are the basis for the gender dysphoria in the first place, evaluating that and treating that consistently and helping the family work in that environment. So it is not really just standing back with your hands behind your back and waiting to see what happens. It involves incredible depth of evaluation of the child, of every one of the parents that's in that child's family, the biologic parents, the mixed family parents, and the siblings, to establish what might be going on beneath the surface. Adverse childhood events are key in being recognized as the focus and cause of undercurrent depression and anxiety in these kids. Conservatively, it's estimated that 60% of transgender dysphoric kids have been sexually abused. And that's a conservative estimate, because it's very hard to tease out true statistics in those kids who many times will not finally come to grips with that until they're 40, 50, or 60 years of age, and they come out from under the shame of that and actually mention it to their therapist. So other adverse childhood events are death of a parent, death of a sibling or a grandparent, death of a close friend. We mentioned sexual abuse, frequent moves. There you go. In the military, a recent little study published in the JAMA Pediatrics evaluated the degree of transgenderism in military-dependent children and found that it was increased compared to the other populations that they used as a comparative in patients that did not move around the globe very frequently. So disruption of what you believe is your home, your environment, your room, your friends. As a little kid, it basically tears one's life apart. And it's very hard to get the military to look at that critically, because frequent moves are part of a military active duty person's career advancement. And so to deny them moves based on the fact that it's traumatic to the family would suggest that maybe they are not fit for promotion. And so it's been something that's been buried along the way, but now is kind of coming up to the forefront. This watch and wait involves intense, persistent counseling of the patient and the family by a compassionate, caring mental health provider. So there is nothing neglectful, nothing harmful that's going on with this in any way, shape, or form. It does not require special expertise to be a counselor, mental health counselor, to treat these kids. These are the same issues that cross all parts of pediatric mental health. And so the concept that you have to be trained in transgender health to be a counselor for a transgender child or someone who's dealing with gender dysphoria is absolutely false. And the impression is that you have to find a center where there's somebody who is an expert in psychological issues for transgender children. And of course, what that does is that funnels you into the big system of affirmative care with no other options. The goal is to elucidate the undercurrent mental health morbidity, help the patient return to a state of positive mental health so they do not need to use gender incongruence as an escape mechanism to get out of what they feel is an impossible life to live. So many of these kids that I've had a chance to talk with have a specific reason why they do not want to be the sex that they were born. They are either abused, or they are bullied, or they are the child that the parent didn't really want. They wanted a child of the other sex. And so the way to solve that problem is very simply to become the other sex. One very sad 15-year-old, very angry girl that came to my clinic and found out historically that she wanted to be a boy when she was 14. And that's when the parents sort of learned about it for the first time. I interviewed the dad and the mom separately, and the dad said, yeah, I don't know what happened. I got divorced from her mother about 4 or 5 years ago. And when my daughter was 14, I got married. And I insisted that she wear a dress to be in the wedding party. And that's the age when that girl wanted to become a boy. No connection at all. But Dad just told that story as an oh, by the way, and it's just there as a light bulb that went on. There's no question. This is how shallow some of these things are in the minds of these kids. If you don't ask the questions, you're not going to get the answers. So the other side is the gender affirming therapy, or GAT. There are psychological and medical and surgical treatments. We'll talk first about the psychological and medical ones. Although recognizing biologic sex, the gender affirmation folks convert social identity and physical appearance to that of the opposite sex. And I emphasize the converts because this group of advocates for this therapy refer to our side, the watch and wait side, as being conversion when actually they are converting the sexual identity of the child. Ideally, it involves an initial psychological assessment of the patient to rule out dissociative disorders. And that's all they want to know. Is this child living in reality? Is this child schizophrenic or not? They don't care about depression and anxiety because they figure we can say that's the problem because they're living in the wrong body. But in terms of they want to get somebody who is schizophrenic, who does not know reality from fiction. And so they'll exclude those kids. But beyond that, that's the depth of the psychological evaluation. What the psychological treatment of that situation is, the family unit, the siblings and the parents are counseled on how to not offend the child who wants to be the new sex. That's the degree of psychological intervention. It's not anything to do with the child themselves. It's everything to do with making the bubble around that child within the home, going to the school, making sure the correct pronouns are used, letting that child live in this fantasy world of being in the opposite sex. It promotes social affirmation of incongruent gender at home, school, and requires now society at large. There are states that are essentially passing laws. 14 states have laws that say that these children must be treated by law in their school environment to be able to use bathrooms of the opposite of their biologic sex, and in some cases, locker rooms. It interrupts puberty. This is the first medical intervention after the psychological interventions, at the very first signs of pubertal development. Now, in a girl, that is averaged at age 10 and a half with the beginning of breast budding, and in a boy, it's at age 11 and a half with an increase in testicular volume. But that's the 50th percentile for those starting things. Girls can be down to age 8 and be considered early but not precocious. Boys down to age 9 with testicular enlargement, 9 or older, early but not precocious. It is actually being pushed in certain centers that the puberty blockers be given preemptively at 8 years old in girls and 9 years old in boys, even though there are no signs of puberty yet. But if you wait till puberty starts and you get it right at the beginning, you're going to stall the changes that have been induced by the native pubertal hormones. Now, what's the purpose of this? Well, theoretically, and this is kind of like thinking like John Money back in the day, got this idea that, when these adults, trans adults, they complain, the women, the men that want to become women, complain that their larynx is too big and their voice is husky and their jaws are too angular, their bodies are physically changed with testosterone. So how about if we wipe out testosterone at the very beginning and keep them in sort of a neutral state, if you will? And the same thing for girls with the breast development and whatnot. So if you block puberty right at the beginning of puberty, then you don't have to put these poor kids through the disease state of puberty. And that's the purpose, is that puberty is really not a disorder. Okay? Puberty is something that all of us in this room went through, I think most of you. Okay? Maybe the little one back there, not yet. And it is not a disease state. It's a physiologic way that we get from being non-reproductive to becoming reproductive adults. It has a lot of angst with it. It has terrible acne for a certain percentage of the population. It takes ballet dancers who are perfectly proportioned as little girls and turns them into girls that can't walk and chew gum simultaneously because their turnout is gone or their hips are too wide. It does all sorts of things that change the physical appearance. And most of us get through that. Most of us have experienced some bad times related to what puberty did to us as we changed through. But we had the support of our families and our friends and our physicians to get us through and make it to the other side and to be happy on the adult end. But this is viewing puberty as if it were sort of a pathologic process that needs to be interrupted. So this period of Neverland is created so the patient can actually then decide whether or not they want to go forward and be changed in their physical appearance, or if they want to go revert back to their natal sex identity. The sad thing is that the kids that are in these clinics today that are treated with these puberty blockers, 100% of them go forward with the affirmation, with hormones. They do not stop. They introduced cross-sex hormones then to bring about the physical changes normally associated with the opposite sex. That originally was to be done at age 15, 16. That's now happening as young as age 10 and 11. So this is kind of a cute little poster that I like to show for the same group that doesn't want to inject animals with hormones. They want, hormone-free milk. And organic, no problem with giving hormones to kids. So the gender-affirming therapy in terms of the surgical options is even more gruesome. They take biologic males and they remove the penis. If the penis has been fully developed, they can use that penile skin to line the perineal orifice. They're going to create to simulate a vagina. If you've put in puberty blockers, such as I Am Jazz, the famous transgender boy who had his penis removed. He had puberty blockers early on, so his penis never developed to any size. It was an infantile-sized penis. They couldn't create any pseudo-vaginal orifice with that small amount of genital skin, so they had to take part of his intestine and create a lining, a mucous membrane lining, if you will, to create his perineal orifice. That has ruptured, caused sepsis, excruciating pain, and draining wounds that didn't heal. So life is not very good when you have to go through all these things, and there's nothing beautiful about it. They take the testicles off, and they create a perineal cavity, sort of a pseudo-vagina, which needs to be consistently dilated with a bougie in order to stay open and not scar down. Now, in biologic females, they do bilateral mastectomies, and that's called top surgery. And they do a hysterosalpingo-oophorectomy, and then they go through the magic of creating a phallus out of something. Don't be grossed out by these pictures, but this is the forearm muscle removed, wrapped with skin that is taken from a skin graft from the thigh to create sort of an artificial-looking penile structure. It has an orifice throughout it that they put a little cannula down the middle to create something that urine can possibly drain through if they wanted to try to do it that way. And then they attach it. And you see the forearm left behind the scarring where that muscle used to be. And that's supposed to be success. So the validation of successful outcomes for the watch and wait is 98% of biologic males across the world. Kenneth Zucker's success was 90%. But of all the world studies compiled together with much larger numbers, 98% of biologic males will realign with their gender identity and their biologic sex by the time they have completed puberty. So 2% fail rate. And we're rejecting this as a failed, cruel treatment option. 50% of those boys who come back to recognize their biologic sex are same-sex attracted as adults. 80% of biologic females will realign with their gender identity and their biologic sex by the time they have completed puberty. And many of those, more than half, will identify as lesbian. So affirmation, outcomes, initial euphoria. There's, how do you feel? I feel I used to have gender dysphoria, but now I have gender euphoria. Okay, that's what's been described to me by one of the patients. The Seattle study of young children, age 5 through 10, it was a 1-year study. What they did to the patient population is they sent out a survey to all of the patients that had gone through the transgender clinic in Seattle and said, if anybody is interested in taking a study on psychological outcomes, please apply for this study. So they had a bias right from the beginning in terms of selection. It was not all patients. It was those that were interested in doing the study. The observers of success were the parents. Is your child happy? Well, yes, they sure are. What was their control group? The kids' siblings. Are your other children happy? Yes, they are. You see, after a year, we have taken these kids, and they've been affirmed, and they are all happy. And they published that study. If you can imagine, that study was accepted for publication in the journal Pediatrics. And it's revered as one of the strongest things to say, this is the basis for increasing that study, not just 1 year, but we're going to do it for 5 years instead. The overall satisfaction rate declines worldwide after 10 years. And these are in published studies for people who firmly believe that this transition process is the best thing to do. The current NIH study, which I just talked about a minute ago, will gather 5 years of data, but it's going to be at the end of 5 years. What we already know from all the experience of the past 40 years is that people begin to fall out of love with their decision by the time they've had 10 years post-treatment. And so if you design all your studies to look at success and it's all before 10 years, you're going to get the answer that you're looking for. Does any of this sound familiar with the research on breast cancer and abortion and depression and whatnot? So it's the same problem that we're having here in pediatric endocrinology. A recent Dutch study was published. It's kind of we've got lots more years than 1 year, and they brought their patients out to 9 years, and then that's as far as they evaluated them. This study in the Dutch study of adults, they only had about 45% of their patient population that came to the study. So the selection bias, again, is very much skewed to success, and even so. But they published that to kind of throw another study out there to say, you see, we have no regret in the vast majority of our patients. The suicide rates in the Swedish study, which is absolutely condemned outright by the trans activists, is that in the population of all 356, every single one of those patients that was ever treated for transgender issues in Sweden up through about 2006, from like 1980 to 2006, they had 356 patients, and they didn't leave out a single patient from their assessment. The completed suicide rate was 19-fold increase over the general Swedish population. And the Swedish population is not a happy population. Getting old in Sweden is kind of like, it really sucks. And so the suicide rate in the winter, where you've got 2 hours of sunshine a day, is much higher than population studies otherwise. But 19-fold increase compared to their controls. And that just shows you that these were patients that were out sometimes 30 to 35 years post-treatment. So the recent reviews of no regret are flawed by poor quality data gathering. There's a Hayes review, which is kind of a cousin of a Cochrane review, that looked at all the studies that had been published about no regret or regret in terms of the kinds of validation therapies for affirmation. And they said there's no clinical evidence of any quality whatsoever because of study size or bias in selection, the kinds of things that you all were referring to with the NAS. So the best thing about being transgender is that you don't have to tell your parents you're gay. Kind of a sad remark, but on the left is the actual cover from National Geographic, which was published and had a couple of people from Hollywood doing sort of articles within that this was a special edition. And then on the right is that you basically are taking people who would possibly end up with a same-sex attracted orientation as adults, and you're removing them and turning them into transgenders. You're medicalizing a psychological condition. So let's get back to where we are in the United States. Dr. Norman Spack, a pediatric endocrinologist, I don't know him personally. I have no idea what he believes in terms of social norms. He left and spent sabbatical time over in the Netherlands to look at what was called the Dutch protocol of treatment of children, not adults, but treatment of children, both medically and surgically. And he returned to Boston and set up the first official transgender clinic in the United States in 2007. So very shortly after that, we began seeing seeping into the literature, what we call the throwaway literature in our pediatric world, little articles talking about transgender. It's this new thing, and we should pay attention to it, and this is a variation of normal. And one of his fellows wrote a little article in Pediatric Annals in 2004. So Dr. Spack and his other colleagues, most of them WPATH members, formed a working committee of the Endocrine Society, and they wanted to import the standards of care that were designed by WPATH to create an Endocrine Society clinical guideline here in the United States. There were 8 members of this committee, and most of whom, as I said, were WPATH members. Notably absent from this working group were the 2 people who had published most widely and were internationally renowned, Kenneth Zucker and Paul McHugh. The authors of these guidelines, it's very interesting to kind of go over them. Wiley Hembry is an adult endocrinologist from Mount Sinai. Peggy Cohen-Ketnes is a general psychologist from the Netherlands, not a medical physician, a general psychologist. It's important to have mental health input, clearly. Henriette Delmar van der Wal, a pediatrician from the Netherlands, not an endocrinologist, not a mental health provider. Louis Gorin, who's an adult endocrinologist in the Netherlands, and Walter Meyer, a pediatric endocrinologist in Texas. Now, the reason I put the little color here is both these guys were about 4 years ahead of me at Hopkins in training. Louis Gorin in the endocrine division of the adult department, and Walter Meyer in my pediatric endocrine division where I trained. And so they had exposure to John Money, and again, I never met Walter Meyer face to face to know if he has any particular orientation or social constructs that might be different than mine. But I suspect that they were indoctrinated by John Money heavily. Norman Spack, the pediatric endocrinologist I mentioned already from Boston, from the US, and that's the makeup of the, there's got to be, I'm pressing the wrong one. There we go. Vin Tangpricha, who's an adult endocrinologist in Atlanta. Interestingly, Vin Tangpricha trained in Boston, where they had a transgender program in the adult clinic there. His specialty is in bone metabolism. He is a calcium phosphorus guru, and that's what he came to Emory to do. But because he had been exposed to transgender medicine in the training program, and Emory wanted to be on the cutting edge, Dr. Tangpricha was essentially placed in charge of the transgender program in the adult side at Emory when he arrived, because he was the youngest man on the totem pole at the time. That's what happens to a young faculty member. Oh, good, I can get off that's your clinic. You get to do these guys over here. So that's what he did. And then Victor Montori is an adult endocrinologist. Adult endocrinologist in the U.S. At the Mayo Clinic. So 5 of them are from the U.S. There are 2 ped endos and 3 adult endos, 3 from the Netherlands, 1 adult endo, 1 pediatrician, and a psychologist. Is that a representative group that should make recommendations for children going through puberty and into late adolescence? And I would argue that's not a representative group of experts that represents a broad spectrum of input and information. The 2009 guidelines, scientific basis, there were 22 total guidelines. Only 3 were based on moderate quality science, and those concerned about the adverse effects of puberty blockers and cross-sex hormones, calling for clinical research to be done before in the very near future. The 19 based on little or no evidence, the recommendations for trained transgender specialists, recommendations for timing of medical and surgical interventions. All of this based on opinion with no scientific validity behind them. The consensus of publication, the consequences of publishing these guidelines, the incidence of gender incongruity in biologic males has risen from the baseline in the old days of 6 per 100,000 males to 3 out of 100, or possibly even 27 out of 100 kids, according to the Williams Institute survey done last year in Los Angeles. The ratio of males to females used to be 2 to 1, but this is reversed. This is showing the advent of social media and the incidence of transgenderism in males and in females. The males are the black line and the females are the gray line. Here comes social media, and all of a sudden the ratio flips, more females than males, and the incidence goes up exponentially. Consequences of these guidelines continuing, number of transgender clinics in the U.S. increased from 1 in Boston to 45 or more across the United States. U.S. News and World Report annual review of best children's hospitals gives higher cumulative scores if you have an active transgender clinic. The AMA, the American Family Practice Association and American Academy of Pediatrics, endorsed these guidelines. Subsequent published guidelines, we've got the 2016 Ped Endocrine Society guidelines, essentially rubber stamping the adult endocrine guidelines, adding emphasis on the fact that there should be regulations to mandate insurance coverage for the expensive therapies. So I know I'm getting close here. 2017 revised guidelines, same lack of science, loosened the age recommendations, and added one very important scientifically valid based concern, and that was you needed to talk about infertility to these people and fertility preservation before they go into therapy, okay? If you block puberty, they never get to Tanner stage 3, where the gonads begin to develop the germ cells to maturity, and then you add cross-sex hormones, and then you take the gonads out. You are sterilizing 100% of your patient population. How ethical is that? So these are the guidelines that were redone by the Endocrine Society. These same names from the old group are there, but we can add in another pediatric endocrinologist from the Netherlands, an epidemiologist from Mayo Clinic in the US, another pediatric endocrinologist who with a very strong agenda at UC San Francisco, and Josh Safer, who is at Mount Sinai, where Wiley Hembry is. Josh Safer trained Vin Tangpricha in Boston, and he was there. So again, a very biased, non-broad spectrum input. And finally, another adult endocrinologist from the Netherlands. So you see there, this is now 6 U.S. folks, 2 ped endos, 3 adult endos, and 1 adult epidemiologist. There's a good person to have on your committee. And then 4 from the Netherlands, 1 ped endo, 2 adults, and 1 psychologist. Making guidelines. Not to be outdone, the American Academy of Pediatrics published in their September issue of Journal of Pediatrics their guidelines. Eliminate psychological evaluation of the child. Affirmation only is the way to go. Watch and wait is medically unethical, stated strongly in those guidelines and endorsed. It suggests leniency of age for medical and surgical intervention and absolutely no input from the general membership of 66,000 pediatricians to have anything to say or have any input in getting these guidelines. It was written by one person and approved by a committee that might have as many as 35 people. That is how those guidelines were published, and they are essentially sent to Congress as the guidelines for our new Equality Act. Today's landscape in the U.S., critics are stifled, publications are suppressed, academic faculty are fired. The head of plastic surgery at Ohio State University in Columbus, Ohio, was let go because he would not teach his residents and fellows transgender surgery. This is a man who had developed incredible procedures for reconstructive surgery for female cancers. Major CME meetings will not accept contrary speakers. Medical schools are developing transgender curricula. You got to teach it somewhere. And research is being funded by the NIH, $5 million grant, 75 patients in 4 centers, affirmation only, no control group. 5-year endpoint. Guess what they're going to come up with? Guess what their conclusion is going to be? Accepted standards of clinical research. If you know it, you have to have informed consent. You have to have age 18 or older for consent, assent between age 7 and 18. Diagnosis must be established by measurable criteria. There is not a test for transgender. You have to have a balanced approach. You need to look at pros and cons, the benefits versus the risks of intervention, and you have to have a randomized control group. They don't have that. The NIH study has none of this. You have to have an institutional review board which is independent of your organization that's designed the study or the pharmaceutical companies involved. You have to have a safety committee which is yet separate that has stopping criteria for anything adverse. Is sterility possibly an adverse outcome? So, what's wrong with the current state of affairs in transgender care? There's no diagnostic test to confirm a diagnosis. You depend upon the opinion of a 5-year-old to make the diagnosis. If they're insistent, persistent, and consistent, they are transgender. Well, that applies to every toddler I've ever raised in my family. Okay. There is no biologic basis for transgenderism. It says so in the American Psychology Association Handbook of Human Sexuality. There is no biologic basis. Arrogance of transgender advocates. There's no dialogue allowed. The Pediatric Endocrine Society sent out a survey last week to find out how all of us were doing transgender medicine, and they gave us options only to say we are giving hormones or we're not giving hormones. And it's essentially a survey of these are all the right answers, check one of them. And if you wanted to have a contrary opinion, you could put it in a box, but it would not accept comments in that box. Misrepresentation of data is legion, just like the NAS studies that's happening across the board in the pediatric endocrine world. Transgender centers are not adhering to the guidelines, which would do basic evaluation psychologically and then giving the patient a choice. 100% of the patients in those clinics, the ones that we know about, are affirmed once they walk in the door. What's the trajectory at present? We're medicalizing a psychological issue. We're creating a significant amount of morbidities for a lifetime. Cardiovascular disease, stroke, cancers are increased in the adults with cross-sex hormones, unquestionably, in very large, well-published studies. The psychological morbidity is persistent. We know that. Multiple thousands of newly transgendered pediatric patients are being manufactured every year moving forward. It is an internet culture driven. The kids go to the internet, they seek out YouTube videos, they become transgender in groups, kind of like a religious cult. and the increasing number of adults who wish to detransition is finally coming to the forefront. Walt Heyer, who is a man who went through living 8 years as a surgically and medically transitioned woman, came back to his senses, got through his emotional illness, and is a strong advocate of detransitioning and inviting people. He has a blog, and he gets at least 7 to 10 hits for patients asking him for information how they can detransition every single week. 6 to 7 patients, and sometimes double and triple that when he is in the news. Okay, so what to do? We don't want to do any harm. We want to halt the NIH study. We want to look at what's happening at these clinics. And we need transparency so transparents can see the whole story, or, as I say, transparency. Thank you very much.